on oncology. To chair this session, I invite respected Dr. Niranjan Chauhan, Senior Obstetrician and Gynecologist from Sion, Mumbai, and Professor and Unit Chief, LTMMC and LTMGH, Sion, Mumbai, and Dr. Mahananda Shete, Senior Obstetrician and Gynecologist from Satara, please. We now begin with the Amogs Uddhav Memorial Symposium in Oncology. Our first speaker today is Dr. Priyanka Deshpande, who will be speaking on GTD genomics and spectrum. I request the chairpersons.
Priyanka Deshpande. She has worked as a resident doctor in the Department of OBGY at HGS Medical College and KM Hospital, Mumbai from 2015 to 2018. At present, she is working as a senior resident in the same institute since August 2018. She has participated in various district, state and national level general knowledge, allocation, essay writing and the sports competitions and received various awards. She has won the Best Poster Prize in Research Society Conference in BJMC Pune. She has won Best Prize in AICC RCOG Conference in Mumbai. She has recipient of the second prize for paper presentation at Amogs 2018 in Pune. She has n number of publications in her credit, which include a covalent uterus due to chronic abruption with a successful pregnancy outcome in 2018, tumor ovarian abscess in sexually navy girl in presentation of a genital cox, and many more. Priyanka, please.
Thank you, ma'am, for that very kind introduction. So the topic for my deliberation today is gestational trophoblastic diseases, genomics and the spectrum. So I would like to cover it under the following headings: basis of spectrum of gestational trophoblastic diseases, the classification of GTDs that we need to know, evolution and genetics. Genetics of GTDs, a clinical perspective, what as an obstetrician we need to know about genetics. So basically, as all of us know, gestational trophoblastic diseases, it is a group of conditions that originate from abnormal hyperproliferation of the trophoblastic cells, which derive from the trophoectoderm, the outer layer of the blastocyst, which would normally develop into a normal fetus. So gestational trophoblastic diseases can be either benign or malignant, benign being a partial or a complete mole, which we are all familiar to, and a malignant condition would be either an invasive mole, a choriocarcinoma or placental site trophoblastic tumor, or an epithelioid trophoblastic tumor. So today we will be concentrating more on complete mole, partial mole and choriocarcinoma because these are the conditions which we most frequently see. So the incidence, coming to the incidence, in Asia it is around 2 per 1,000 pregnancies, which is definitely more than what it is seen in the Western world, where it is around 1 to 2 or even less than 1 in some countries. And the epidemiology of GTDs definitely differs worldwide from country to country. Even the incidence of complete and partial molar pregnancy differs, not only because of the genetic constitution, but also because the way they are diagnosed. To diagnose a complete molar pregnancy is very easy on a ultrasonography. That is why they are more commonly diagnosed, whereas partial molar pregnancies are more commonly confused with incomplete abortions, and that is why their incidence is reported to be less. However, as you can see from this slide, partial molar pregnancies are definitely more than complete molar pregnancies, and the incidence of choriocarcinoma is nearly 20% in complete molar pregnancies as opposed to around 5 to 6% in partial molar pregnancies. So coming to the genetics, basics of the genetics, a complete mole can either be because of one sperm which has fertilized a egg with no maternal DNA, and then there is a duplication of the sperm which is called as the androgenetic mole. It is the androgenetic origin of the mole. Or there can be two sperms which have fertilized an empty ovum, that leading to again androgenetic mole. Or in cases of partial mole, it is usually two sperms with one egg, or one sperm with two egg and a defective meiosis which happens later on. Now, coming to the history and evolution, I would definitely like to include this paper. So it was basically Kaji and Okahama in the year 1977 who first thought about the genetic evolution of moles. Initially, only moles were thought to be aberrations or some kind of tumors, but it was actually Kaji and Okahama who gave the concept that molar pregnancies are androgenic genetically, and thus they are two sperms or one sperm fertilizing a ovum with no maternal DNA in them. So androgenesis is basically development of an ovum under the influence of a spermatozoon, the egg nucleus being either absent or inactivated. So then after this landmark paper in 1977, we had various studies, one in 1980, one in 1991, which again substantiated the theory by Kaji and Okama, which said that formation of complete moles is actually because of an anuclear empty ovum, which is either fertilized by one sperm or two sperms. So the origin of partial moles was then studied because first we came to know the origin of complete moles. So partial moles are triploid, have maternal chromosomal set, yes, and are associated with the presence of a fetus. This is the key differentiating feature between partial moles and complete moles. And then it was proved that partial moles and complete moles are two completely different entities. The two syndromes are pathologically distinct, and although they have morphological resemblances, yes, they differ in their biology and there is no transition in between them. In contrast to complete mole, no choriocarcinoma or very little chance of choriocarcinoma is seen in partial moles, and hence it is very important for us to differentiate clinically between complete moles and partial moles before we start treating them. Yes, there are again some genetic aberrations. It is not black and white as it is seen. So we have got tetraploid partial hydatidiform moles also. We have got tetraploid conceptus with 3 parental contributions also, and we have got diploid hydatidiform moles with fetal blood cells in molar villi also. So these are the things which still continue to baffle us and tell us that we have not reached and we do not know the genetic evolution of moles completely, and still further research is needed in this field. But what at present do we know then? Genetics of molar pregnancy, what are we looking for? Why genetics in molar pregnancy is important? We would think when a patient comes to us with a USG suggestive of a molar pregnancy or clinical features suggestive of molar pregnancy, we would post her after completing all the pre-anesthetic evaluation for suction evacuation and send the products for conception. And then put her on post-evacuation HCG surveillance, depending on what the result has come, either for 6 months or for 2 years. Then, where is the role of genetic testing in these patients? So the role for genetic testing comes for karyotyping and ploidy of the moles, P57 KIP2 mutations, whether they're present or absent, and NLRP7 and KHDCL3 mutations. At present, this might all seem like Greek and Latin to you, but I hope in the next few slides, I will shed some light on each of these aspects. So when we do this genetic testing, how do we look for it? This is a very practical question that yes, I have done suction evacuation, I have a sample. Now how do I process this sample and where do I send it to? So the traditional gold standard was yes, histopathology. We would send this to the pathologist and they would give us a diagnosis, whether it was a complete or a partial mole. But now we have got better techniques. We have got cytogenetic analysis, we have got DNA flow cytometry, we have chromosome in situ hybridization, just like fluorescent in situ hybridization that we normally do for other pregnancies. Molar genetics testing is also available nowadays with microsatellite analysis, and immunohistochemistry forms a very important part about genetic testing in moles with P57 KIP2 staining. Next comes the question, why, after how? Why do we look for genetic testing, and what is a clinical perspective into genetic testing of hydatidiform moles? So the 4 important things that we need to remember when we think of genetic testing in moles is A, to confirm the diagnosis. 1, whether it is a partial mole or a complete mole, and second and most important, whether it is a molar pregnancy to begin with. This question comes because most of the early abortions come to us, most of the patients come to us at early abortion at 6 to 8 weeks. When we are doing a viability scan, we find that the fetus is hydropic. And at that stage, many of us would either tend to diagnose it as an incomplete abortion, a missed abortion, but we do not keep the diagnosis of a molar pregnancy till it comes on later and it becomes a big complete mole. So to confirm the diagnosis is very important. Recurrent molar pregnancies and family history of moles. Yes, we do now have patients who come to us with history of recurrent abortions. But all the time, instead of just thinking about APLA, and APLA that all of us think about, it is very important that we think about molar pregnancies as well, because they are a very important cause of recurrent abortions. And then comes family history of moles. We have got papers in which 3 to 4 generations, the patient herself has got a molar pregnancy 2 to 3 times, her mother has a molar pregnancy, her sister has a molar pregnancy. So what is the role of genetics in these patients? And next is the effect of molar pregnancies on in vitro fertilization. This is very important to us as infertility specialists and obstetricians. Does genetics have a role in patients who have had molar pregnancy? Do we need to do genetic testing in them? And finally, stratifying the risk for malignancy in molar pregnancies. So for the first point, to confirm the diagnosis, I have put up 3 ultrasonography pictures here of early pregnancies. The first one being a complete mole, the second one being a partial mole, and the third one being a hydropic abortion. Leaving aside the second picture in which it is very obvious because the fetal parts are seen, but if you pay attention to the first and the third one, you will find that there is very little difference. So at this stage, it is very difficult to say whether this is an abortion or this is a molar pregnancy. So this is the time where genetic testing will help you determine the difference between a molar pregnancy and a hydropic fetus. And that is the role of karyotyping, ploidy, and P57-KIP2 immunostaining and flow cytometry. Next, molar pregnancies always suffer from the same problem as I have already stated, from either underdiagnosis or overdiagnosis. So hydropic fetus might be diagnosed as a complete mole, and mind you, it is not only the diagnosis, it just doesn't stop at the diagnosis and the suction evacuation. But if you label a product of conception as a molar pregnancy, you are going to put this patient for post-evacuation surveillance at least for 6 months or 2 years. So she will have to keeping coming to you for beta HCG follow-ups, and then if at all a choriocarcinoma is diagnosed, then it will be a different ballgame and she will have to be given chemotherapy. So misinterpretation of early complete moles as hydropic abortuses or partial moles should not be made, because they may carry similar clinical implications as an advanced complete mole, and hence at this stage the diagnosis is very important, and this is where genetics comes into play. Again, we have got a few very unusual case reports where many solid malignancies that are completely non-gestational in origin can mimic these molar pregnancies. So you have a very big solid mass in the uterus, you do a sonography and you diagnose it as a case, as it is described here, as a case of uterine adenocarcinoma. But just to highlight the fact that molar pregnancy is a completely curable pregnancy, barring a few cases which are resistant to treatment. That is why the treatment for a molar pregnancy and a uterine adenocarcinoma being very different, the diagnosis again here becomes very important. So early pregnancy confirmation of the diagnosis, and second, in such ambiguous situations. Now comes the topic of recurrent moles. So the risk for further molar pregnancy after 1 molar pregnancy increases to 1 in 80, and after 2, it comes to 1 in 7. So initially, no attempts were made to identify the causative genes until a report by Seward et al. Showed that the mapping of the first maternal locus on chromosome number 19 has a locus for recurrent molar pregnancies. So familial recurrent hydatidiform moles is now a well-known entity, FRHMs, and it is not extremely rare as it was initially thought. It has now been confirmed that a NLRP loss mutations is the major gene seen in the cases of recurrent moles. Now, how is this clinically relevant to us? So, I have got a patient who has come to me with a second or more than 2 molar pregnancies. If I do her NLRP mutation, and yes, she is positive for an NLRP mutation. Usually, patients ask us this one question after every adverse pregnancy outcome. A, am I going to have this again in my next pregnancy? And B, what are my chances of having a normal pregnancy the next time? So this slide, I'm going to try to answer a few of these questions. So in cases of recurrent mole, when the patients ask us if the next pregnancy is going to be normal, if I do her NLRP mutation analysis and yes, it comes out to be positive, then I have to counsel the patient for ovum donation because there is a problem in her ovum and she might have to need ovum donation and IVF to have a chance of a normal pregnancy. However, if this comes negative, there is another but less commonly seen NHDCL3 mutation. If that comes positive, again, I will have to counsel the patient for ovum donation. However, if that does not come positive, then I need to really review my histopathology to see if actually it was a case of molar pregnancy. And then again, if there are 2 complete hydatidiform moles, it goes into the first bracket. If there are no hydatidiform moles, then I still counsel her that yes, her next pregnancy might also be a molar pregnancy, but she still has a advantage of having a live birth from her own ovum. And that is the time where the pre-diagnostic screening comes into picture. And last but not the least, but the most important is for risk stratification of malignancy. It has now been suggested that only giving a diagnosis of complete mole is not enough. It is suggested that whether the complete mole is heterozygous or homozygous also has a relevance because homozygous moles are known to be more aggressive and they have got more risks of turning into choriocarcinoma than have got the heterozygous moles. So with this, I end my presentation and I hope that I have done justice to my topic. Thank you.
Thank you, Dr. Priyanka. It was a nice lucid presentation where you have given opening to a new era of genetics in the management of gestational trophoblastic neoplasm. Usually, as we have such patients coming, we do suction evacuation followed by sending it to histopathology, and after that the patient usually gets lost for follow-up in 70 to 80% cases. At least I would suggest that in a municipal setup or probably in a private setup, if you have 2 or more molar pregnancies, this option should be given to a patient. I just want one question to be answered by you. What is the cost of this test and where is it done?
Sir, at present, FISH and chromosomal in situ hybridization tests are the only tests which are available in the city of Mumbai as of now, what I know. The other tests and immunohistocytochemistry for KIP2 mutation staining, I'm not aware of the exact cost of the test, but these 3 tests are available. Rest of the tests are still not available with us.
Okay, so I think it's an eye-opener to all of us, and you have done a wonderful job. Thank you so much.
Thank you.